and welcome to the first in a series of presentations on the value of enhancing the topic of addiction medicine within the curriculum of a student's general medical education and how it can be done most effectively. This program is funded by the Opioid Response Network and presented by COPE, the Coalition on Physician Education in Substance Use Disorders. COPE is a voluntary organization devoted to improving patient care and the public health by ensuring that all physicians are trained to prevent, identify, and provide specialty-appropriate interventions for patients with substance use problems. I'm Dr. Steve Wyatt, the COPE chair, and it's my honor to introduce today's participants, Dr. Frank Bailey, who will be moderating a discussion with Dr. Sandeep Kapoor. They will be discussing the importance of building and then infusing an addiction medicine curriculum within the general medical education. Dr. Bailey received his education doctorate in transformative leadership from the University of New England. He is a medical educator at Northern Light Health, Eastern Maine Medical Center in Bangor, Maine. He was involved in the design and implementation of the first osteopathic longitudinal integrated clerkship at the University of New England's College of Osteopathic Medicine. Frank is also a board member at COPE. Dr. Kapoor is faculty at the Zucker School of Medicine at Hofstra Norwell and vice president of emergency medicine addiction services at Norwell in New York. He was instrumental in the development of interprofessional undergraduate, graduate, and continuing medical education curricula and implementation of universal approaches to addressing substance use at Norwell Health. I would note he has been passionate about motivating organizational culture change to drive humanization and enhancement of patient care and community health. It's my pleasure to welcome you both. Dr. Bailey, I'll turn it over to you.
Thank you so much, Dr. Wyatt. Very excited to be here today and just discussing this topic with Dr. Kapoor. There are so many things that you've shared in the past, but I think to kind of start us out, could you please tell us a little bit about your background and how your work at your organization led to the development of this impactful addiction medicine program?
Sure. Yeah. Thank you very much for the kind welcome, Dr. Wyatt and Dr. Bailey. It's a pleasure and honor to have this chat with you. I think this journey that myself and my team have been on started roughly around 12, 13 years ago, where we were charged to implement some screening tools to address substance use as part of usual care. And very quickly within our organization, at that point, we were focusing on 4 emergency departments and 4 primary care practices. We learned very quickly that there was an extreme amount of discomfort around this topic. People felt it was from the patient and community side, but what we unveiled very quickly was that it was actually from our healthcare professionals. There was this feeling of this is not something appropriate to ask about. It's none of our business. People would get angry. And that, I would say, learning opened up this journey towards medical education and really, first and foremost, taking inventory of what we were currently teaching our healthcare professionals in terms of medical school and nursing school and other health professional schools. And then, finding the right mix of leadership buy-in and willingness to diversify curricula to allow us to build a new and diversified current curriculum, but build, I would say, robust and longitudinal curriculum around substance use within our medical school that has now been infused into our nursing school as well as our school for physician assistants. So much that we've learned over the years, but it really started off by trying something new, seeing what we thought was pushback at first, but then diving a little bit deeper and exploring and understanding it really wasn't pushback. It was discomfort that was deep rooted in the lack of education that healthcare professionals have received around this topic.
Yeah, it's quite a significant shift. I mean, it's notable that all the work that you've embarked upon going from a minimal footprint to a comprehensive curriculum in addiction education. You had mentioned about the buy-in and the kind of reticence to move forward. Could you elaborate on the evolution? Like, what were the initial steps? How did you expand the program scope? Could you just kind of share some of those things?
Sure. So, and I think if it's all right, I would like to level set a little bit. Like, this primarily is not an addiction focused curricula that I'll describe. It really takes it back to the beginning of the spectrum of just substance use, right? Just the importance of thoughtfully and with some consideration starting a conversation about and exploring someone's relationship with alcohol and drugs, well beyond and well before someone may progress to a substance use disorder or addiction. But yeah, very briefly, we were a very new medical school, and we did a very quick inventory, and we saw there was possibly, give or take, about 45 minutes to an hour that was dedicated around certain systems in the body. And when it came to the liver, there was a touch point about alcohol. But there was really nothing else beyond the impact, the physical impact to that system. Nothing had to do with alcohol use disorder, nothing to do with screening, harm reduction, pretty much any of the domains that we were talking about, substance use and substance disorders now. That was, in my opinion, a ripe stepping stone or ample opportunity to open up the floodgates and suggest that, to match what we were trying to do in our large healthcare organization, why not start educating the medical students at a younger age, earlier on in their career, about the value of evidence-based screening when it comes to alcohol and drugs? Primarily learning on how to start a conversation in a non-judgmental, non-confrontational manner, as well as gain some insight on risk stratification. If someone is at risk of a substance use disorder or already dealing, let's say, with a substance use disorder. So that yielded a 2-hour session in first year, focused on evidence-based screening tools and alcohol use disorder. We did bring in an individual lived experience to share their journey as well, so that we could drive home this connection piece that we all have, right? There's no 6 degrees of separation here with this topic. So we wanted to bring someone with lived experience early on into this process, so that the students, the learners, as well as the faculty, had this, I would say, emotional connection to the topic that wasn't fueled with the jadedness, but really fueled by hope. This individual was in recovery, so they were there to demonstrate that treatment, as well as other modalities of care, are feasible, and recovery and well-being is achievable. That over the years went from 2 hours to 4 hours to 8 hours to now, fast forward, we have close to a 30-hour 4-year longitudinal curriculum from first year, second year, and third year that really prepares our medical students at Hofstra to model up as they continue through their clinical internships around the clerkships around Northwell, but also as they continue out into their residency programs around this country. They are better prepared than the average bear at this moment.
I would say so. That's quite a step from just a 45 minutes to an hour to 30 hours of opportunity to really get their minds wrapped around it. Those initial conversations that they have, it's not something you typically step into with just someone you meet on the street. So yeah, that training, that very intentional effort is phenomenal. And so just to clarify, those initial efforts were expert screening, correct?
Yeah. So pretty much it was introducing them to the audit C, if you will, and the fuller audit of 10 questions. So it was a screening that we were trying to implement in our organization. And we figured that let's prepare these folks, let's evaluate what we're teaching them. And then, fast forward, we modularized so much of what we've done at the med school into graduate medical education for multiple residency programs and disciplines, as well as continuing medical education.
That's phenomenal. And SBIRT is something that is, I've been through a training and had the opportunity to sit in on that. It's so foundational to the conversation, and it challenges some of our assumptions. And you had mentioned that you had kind of experienced some challenges from folks, and that there was some pushback, but it was actually a lack of education or discomfort rather than resistance. Now, how do you address that through interprofessional approaches?
Yeah, thank you for that. So just for everyone, by the way, SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. And frankly, yeah, it's a protocol. But let's remove substance use for a moment. It's the same exact protocol we use for heart disease. We take someone's blood pressure, it's screening. We talk about their diet, their weight management, their potential for heart disease. That's your brief intervention. And then referral to treatment would be providing medications or referring them to cardiology. So same exact protocol, but superimposed onto substance use. So it's at first, to your point, Dr. Bailey, there was a lot of pushback and a lot of uneasiness because this sounded different, right? This was something completely out of the ordinary. One thing that we were very successful in doing is actually normalizing it and bring it back to basic and say, wait, we're doing this for heart disease and diabetes without even a second thought on a daily basis. If we can open up this gateway to understand someone's risk level for a substance use disorder, the same way we're doing to understand someone's risk level of heart disease, we can accomplish a lot. And in terms of really navigating, we have to look at the value of real estate in medical schools, right? So we know very much real estate for time in medical schools is like New York City real estate, right? Like extremely expensive. It's very hard to get your hands on. Everybody's competing to get that best, the time slot, as well as just any airtime. What we were able to do creatively with a lot of our partners, I get to voice out this journey, but this journey's been populated with thousands of fellow colleagues and partners along the way and interprofessional colleagues as well. But what we were able to do is really vocalize this thought process and vision that we're not trying to add net new. What we're trying to do is diversify. So for example, that evidence-based screening tool session in year one, we talked about depression and depression screening because that was very much a thing that we were trying to implement as well around the health system and around the country, I would say. And that evolved into anxiety screening. So we were able to take over or save some time from other sessions where things were being discussed and put them all together in one session. And that brought a lot of value to our medical school leadership, which then opened up many other doors to continue to diversify as opposed to add net new. Like we didn't add 30 hours to the 4 years the medical students are there, right? We literally worked with them creatively and flexibility diversify. And another reason why we were successful that is, to your point, Dr. Bailey, interprofessional. So there has been, I would say, a realization of the real world in medicine is a team sport. It is not just the physician and not that traditional pyramid of doc on top and everyone below. It's not like that out there, right? You need to know how to communicate and work well in the sandbox with your fellow colleagues that are stemming from different professional journeys. So we know very well that even when it comes to substance use disorders and for patients or families, it takes a village. So we brought a village into the medical school right from the get-go. So they were not just learning from their faculty members that are there for communications, stemming from different departments, but we brought in social workers, licensed mental health counselors. We brought in patients and community members. We brought in our health coaches that were part of our SBIRT team. And we allowed the students, to, in my opinion, to visualize as well as manifest this important shared understanding that in order for us to be successful in helping individuals, we need to be flexible in our mindset to bring an interprofessional workforce to the table. And throughout the 30 hours at the medical school curricula and all the other touch points we have, we always ensure that to our best that our faculty and facilitators are interprofessional. And then we also encourage that our learners are interprofessional too when we get the opportunity. So mixing our medical students and our nursing school students and our NP students together, our pharmacy students together, so that they can learn at the same time.
And that sounds so wonderfully authentic. And I think that's why the experience really captures not just how do we work together as a team, but when you bring those patient-facing opportunities, they really take hold. And so, to leverage that, to bring those folks on board, there had to be an open window for change. And so thinking about, the fact that you were with a newer medical school, was there a flexible mindset in integrating some of these different components, trying to move them from substance use disorders and harm reduction, trying to get those things going? You said you brought a bunch of folks together. What were some of the factors that played into that?
Yeah, it's a great question. Uh, yeah, no. So even to this day, we deal with a lot of, I would say, in your face pushback as well as behind the scenes espionage or sabotage, right? It's a challenging topic, but I think what we learned really early on that this can't just be a protocol or something that's directed to for us to do in healthcare by insurance companies or by the federal government. Like we realized that there was a deep and palpable connection to this topic. So, if I may, I'll just share with you, like we tried to harness some of the energy that we were receiving when talking about these topics, when we're trying to just sit around, let's say, the conference room table to plan things out, coming up with a faculty plan, or even just coming up with a strategy on how to approach, let's say, decision makers. And what we found was that around the room, everyone was impacted in their own home or in their community, either by alcohol use, by substance use, by overdose, by recovery, right? So that everyone had some touch point in their journey with this topic. And what we realized was if we were going to drive macro change or even, I would say, prepare an environment for change, we really needed to focus on the micro, which was all of us. So we started creating multiple, I would say, destigmatization strategies and opportunities for our own 108,000 healthcare professionals on the Northwell Health side, as well as for our medical school faculty, our nursing school faculty, and the students to start to reflect about the importance of this topic and if they are willing to recognize their power in changing the narrative, right? So what does that look like? I mean, it sounds really grandiose, but very simple things. We started to promote a share your story campaign early on because anecdotally, a lot of folks would tap me on the shoulder after a meeting and say to me, I really appreciate what you're doing. You know, I lost my son or my daughter or my uncle, my cousin, myself, I'm in recovery. Like the amount of shared experiences that were coming my way from folks that, you know, again, we think we know the face of addiction, right? We think we know what it is because socially we've been taught it's the needle of the arm or someone that smells like alcohol or looking a little bit disheveled. But the reality, it's all of us. We're all the face of addiction. So by hearing all these stories, but then understanding that I'm the only one hearing them, I can amplify them individually, but why not allow for others to reflect on a macro level by really reflecting on a micro level, right? So we open up all these different opportunities. We started to observe International Overdose Awareness Day every year. We created CME like activities where we brought fellow team members to, let's say, the stage to talk about their journeys of recovery. So fellow healthcare professionals in recovery coming in. We had community members, family members, and we just started to create this momentum of, I would say, shared accountability, if you will, where everyone, in my opinion now, regardless of clinical or non-clinical, has something they could do to help patients or help community members that may be struggling with the substance use issue. And we brought the same knowledge that and lessons learned from the health system into the medical school. And I would say full circle, everything we've learned at the medical school and evaluated from the students' feedback, we brought back into our large health system.
That's such an amazing program. It's a creative way to overcome stigma. It really is, it really personalizing that and giving opportunity for that catharsis to occur and a safe place for that to happen. It's a scary thing to do, to step out there. So you started this process 11 years ago, roughly?
Yeah, we're actually just about to hit 12.
Wow.
Just about to hit 12, yeah.
And so back then, and not to make it sound like it was that long ago, but addiction was even more stigmatized than now. So, as you had the share your story, as you had the different events, there must have been opportunity to really destigmatize the conversation and really gain buy-in for this sensitive topic. What were some gems or some little nuggets that you could share from those experiences?
Yeah. First, I appreciate you framing it as if it was some big innovation, but I will just say, a lot of this to us as a group, it's not just me, but like a lot of this is common sense. And we just needed to we needed to create opportunities to just hit the reset button along with others. I'm sorry, allow others to hit the reset button in their socially primed thinking, right? So regardless of where we come from, or what we look like, or what language we speak, whatever it is, we all had a dinner table at some point in our lives. And around those dinner tables, this conversation was fueled with derogatory language. This conversation was fueled with hatred, with judgment, with tons of guilt, and unfortunately, a lot of hopelessness. Fast forward, right? You become a medical student, you become a healthcare professional, you are wearing these fancy IDs and all these degrees behind your name. No one's ever allowed us to reset the thinkings and the learnings we had at that dinner table, because frankly, we know medical schools, nursing schools, every healthcare professional school is lacking in terms of dedicated education around this topic. So we bring in all those socially primed stigmas and all those socially primed stereotypes, and we're committed to help people. Like it kind of like it's when I say it's common sense, it's also like nonsensical. So one thing that I think that brought a lot of value along this journey was literally stating it as it was, which is, hey, we need to shift our language. There's no point of us talking about being better. There's no point about talking about implementing protocols or learning about medications. We need to first foster an environment that's actually welcoming with our own words. So, and we're not the first ones to talk about this. I mean, there's been things written up about how much words matter, but like, let's not talk about substance use for a second. Like, I think all of us that have been through middle school or high school in this country know that calling someone fat is extremely inappropriate, and it could cut really deep, and it could lead to a lot of downstream consequences to that person's well-being. We don't really hear that word a lot used much more, because all of us now, as our generations continue to grow, we realize the value of the hurtful value as well as the positive value of our words. So we started to propel this thought process about substance use disorders and how much words matter, and to drop the word substance abuse completely. Remove it from our vocabulary, get all that negative connotation, the criminality of these terms, and just talk about substance use. And that goes back to our curriculum. It's called Addressing Substance Use. That whole 30-hour curriculum is called Addressing Substance Use. It's not addictions. It's not substance use disorders, because we want people to start off appreciating and understanding the ground level, which is alcohol and drugs, and utilization of such has been happening for centuries. We need to understand it. And we need to understand that some folks may be dealing with the beginning part of the spectrum at some risk of substance disorder, and many people may also be dealing with addiction or substance use disorder at the farther end of the spectrum. So we also continued with this words matter thought process and directly challenged people that if you as a healthcare professional are calling somebody an addict or an alcoholic or a junkie, that is a perfect moment to pause and reflect on action, because those words are extremely harmful. They're labeling, they impart a lot of judgment and shame, and all you're doing is putting up a barrier and saying you're not welcome here. And then another example of this is we would talk about how we very openly talk about a drug screen being dirty or clean. And I would make this analogy that, like, I never heard someone's high blood sugar being called a dirty blood. Yet we do this with alcohol. We do this for drug screens and urine toxins all the time, as opposed to just saying positive or negative. And what I'm describing to you takes zero money. It takes very little investment other than personal motivation investment, because reframing this language and using person-centric terminology, you're automatically creating this welcoming environment, not just for patients and for community members, but also for your fellow colleagues that are all been impacted by this emotionally in their own homes.
Yeah, I think something that you do incredibly well is that you make these connections, and it makes it seem so. Why not? Why not change your mindset? Why not change your perspective? And at the very deepest part, it's the core values that we're bringing to the surface. And you do a wonderful job at inviting individuals into the narrative and really foster that self-reflection. The share your story is one example of that. Could you give some other examples of how you've done that? I mean, you've done it well for me now in just this interview, at least 4 times now. But maybe there are questions or exercises that encourage personal connection to the topic. Share your story is a great example. Were there some others that you can think of?
Yeah, first, Dr. Bailey, you're being way too generous. I mean, it's very, very nice of you and very generous of you to reframe back to me some of the things that are very hard to deconstruct sometimes about the why of certain things, of how they work. But I promise you, I have received tremendous amount of guidance throughout my life from my parents, and I got to be honest with you, it just comes down to basic humanism, and I think that's what you're getting at, right? And literally that's what we try to drive here is our current process and system is failing. It's failing our communities, but when you even say communities, it's such an external term. It's failing us. It's failing our next generation, our families, our children. Because frankly speaking, if you were, let's say about 10 years ago, to go into any emergency department in this country, most likely you probably would not get the same level of care you would now when it comes to, let's say, a potential overdose or coming in intoxicated. I want to believe, I'm very optimistic, that I want to believe that we have changed our approach. We are humanistic. We understand that individual is a lot more than their alcohol use disorder or their substance use disorder. And we need to see that. And we have with so many other things. But it is about driving this, I would say, question is, what are we doing for others? So Martin Luther King, it's actually a quote from Martin Luther King. He said, life's most persistent and urgent question is, what are you doing for others? And as healthcare professionals, we do a lot for others. But if you remove the word others and replace it with individuals dealing with a substance use issue, that is globally a much more challenging question to confidently answer and comfortably respond to. But we need to ask and answer because we know the prevalence of these disease processes, overshadow heart disease and diabetes individually. So we need to do more. And when it comes down to, I would say, healthcare as a whole, or even medical education, sometimes we get caught up in how much is it going to cost us? Are we going to make money behind it? What's the return on investment? And yeah, I'll be the first one to say, I don't like discussing the financial return on investment short term, right? We really need to look about the total community health return on investment by changing our approach, diversifying, evolving so that we meet the cries of our community. So another example I'll give you that could serve as a point of reflection for, I would say, the general public. But again, sometimes in healthcare, we're not any better than the general public because we have the same negative baseline education around this topic. But a lot of folks say that there's no help available out there, right? Treatment doesn't work for substance use disorders, right? You have scientific folks saying it. You have lay people saying it. You have family members that have witnessed their loved ones go in and out of treatment or not want to seek treatment. And the thought process, the misnomer is there's no help out there. But what have we learned, in all honesty, through our education? All we've ever seen on TV and radio or heard about is detox and rehab. So everyone needs detox. That person has a problem, they need detox. They need to go to rehab. Like, it's our knee-jerk response to these things. But when you dissect that a little bit, first and foremost, the treatment, I would say, philosophy for substance use disorder is no different than heart disease or diabetes. It's about the social, biomedical, and physiological needs for overall health. And that's what the goal is for substance use disorder care. But also, like, if you have high blood pressure today, how many of us are actually going to see an interventional cardiologist tomorrow? Like, it just doesn't make sense. But we're saying everyone has to go to detox and rehab. And no one's ever taught us that there's a robust landscape of outpatient care available, and now even more so evolving through addiction psychiatry, that could be considered outpatient, through addiction medicine, through internal medicine, through family medicine, through emergency medicine. I mean, you name the discipline, pretty much anybody now can at least initiate the process of treatment for substance use disorder. But then when you think about substance use disorder, like certified settings like clinics, there's a huge landscape of outpatient care, and we don't capitalize on the fact that this is a starting point as well as a continuation point, right? Because if we frame this as a chronic medical condition, We need continuity of care. Someone may go to detox and rehab, but they don't get connected to outpatient care. And that's where the vicious cycle of that misnomer that no one ever gets help and nothing's available. So as we try to gently enlighten our colleagues and students about this, I do think it drives some reflection about what we think we know versus so much we still need to learn.
Yeah, absolutely. And I think, anytime you're doing work that inherently involves challenging assumptions, you're really driving culture change, and specifically in medical education. So when you think back about your experience and all the crucial elements for initiating and sustaining this kind of cultural shift, what do you do when you're dealing with deeply ingrained societal attitudes towards addiction? You've definitely given us a lot to think about regarding, the dinner table conversations and how that persists. But what are some other things that we might consider?
Yeah, it's a great point, and it's also, I think, a great cross section where we need to remember that even as we try to develop curricula and implement curricula, we are still dealing with human beings. The same way when we're trying to partner with an individual that's contemplating a change in their life around their alcohol or drugs. So what we see as potentially resistance, that we may say resistance, is probably ambivalence that's fueled by a lot of the socially primed stigmas that we bring to the table. So my quick response to that is we have to be patient. We have to also be understanding, right? We cannot force this issue upon people because, yeah, we could click the checkbox, pat ourselves on the back and said, yeah, we did X, Y, and Z. Or if we really are trying to motivate not just culture change, but sustained culture change, we need to be flexible, and we really need to understand and appreciate the autonomy of the individuals that we're trying to reach. And I know all these terms are resonating with yourself and with Dr. Wyatt and your listeners, because I'm literally trying to prove that all this stuff is interconnected. The world of medical ethics, autonomy is one of the 4 pillars. Giving people the decision-making power that they deserve. It's the same way you would do with trying to motivate an individual to either make a change with their diet, or to start a new medication or continue a medication, or to contemplate a change with their alcohol or drug use. We could be directive and push it, or we could take a step back and figure out how do we truly motivate those internal generators so that we are not pushing, but we're traveling alongside that individual. And that's where, on a micro as well as at a macro scale, that comes into play.
And that's the beauty of the spirit of the process, that we can move them from pre-contemplation to contemplation to preparation to action, and then maintenance. That's where it gets tough, right? We've got to be ready for that relapse to kind of kick in, that they might fall back on old behaviors. Yep. So speaking of which, beyond stigma, what were some unforeseen challenges that you encountered during this process? Like, how did you prepare for and address situations where, boy, oh boy, there's going to be some strong emotional responses from participants?
Yeah. So I think the lesson I learned many, many times, and it was a great moment for me to also kind of take a step back and learn about myself. Egos are primarily the biggest debilitating factor sometimes, because the reality is sometimes folks are not open to ideas that are not theirs. And, it's a challenging process. We go through this on a daily basis, regardless at work or at home. But it is something to keep in mind, that no matter how emotionally connected someone could be to this topic, right? So if we could achieve that internal motivation that someone feels like, yeah, we should really do something about this. Even with that, sometimes ego comes in the way, and it starts to defeat that motivation, and it becomes the exact opposite, which is like a barrier. So that's one thing I would just say, look, no matter what organization we work in, no matter what community we serve, we're dealing with other human beings and other individuals. And I think sometimes it's okay to hear no. But it's also very well okay to respectfully find workarounds to get things done. I have tons of stories when it comes to the implementation that we've done around our large healthcare system about the simplest things that you would just blow your mind about why people were saying no. But every no for us was a pivot point to go and venture and find a yes. From from electric health record integration of 2 to 4 questions that took 16 months to accomplish, to bigger things, which is trying to even get airtime at faculty meetings to talk about this topic, to offer CMEs. To even have the buy-in from non-clinical departments to be part of this process, from HR to legal. And, I think, again, that's where it comes down to all of these barriers that I could come up with or challenges. Every single one of them actually served as an opportunity for us to learn, as well as potentially grow that village even bigger. We're getting pushback about something. Well, why don't we go have a conversation with them and see where they're at? And not just see where they're at, but understand what their understanding is about what we're trying to accomplish. And then find a middle ground.
It's wonderful to hear how seamless and congruent your process is. That willingness to truly listen, to genuinely listen, and to seek out, how can we not just get our goal met, but how can we also meet the other person's needs in this process, and really thinking about, who is on that team, who's vital to your team. And so with that in mind, in your view, who are the key individuals or maybe roles that need to be involved to successfully implement and sustain such a comprehensive program? Maybe it's interprofessional or interdisciplinary. How do you get them to move away from that siloed thinking? Because you mentioned ego. So there's got to be some silos there. How do you get the shoehorn out and move them?
Yeah, so again, it's more to motivate than move. The end goal, obviously, that we're all moving together, right? And in harmony, as opposed to the silos, as you mentioned, that are, fractured, and the fractures expand, and all of a sudden there's really no cross communication. I'll say one of the things that I've learned over time from mentors, as well as just lived experience with trying to navigate this world that hasn't always been welcoming to these topics. It's important that you're not the sole voice. So what I mean by that, like right now, obviously it's you and I chatting, and I'm representing what sounds like seamless. By the way, it has not been seamless by any means, but what sounds like a great journey, but this journey's been populated with tons of what I would say failures, or what others would say failures. And again, I would say they were all learning opportunities, and we grew from them. Going back to implementation science, right? Like, you need to be willing to hear feedback. You need to be iterative with your process. And along the way, you need to really understand who your stakeholders are. And if you take a broad look at that term stakeholder, then honestly, it's everybody is a stakeholder. Everybody's a decision maker, especially if what our main goal is to individually motivate them. Right? If we're talking about on an organizational level, yeah, you're trying to reach 1 or 2 decision makers so that the organization can directively say, okay, we're going to do this. But like I belong to an organization that's 108,000 of us. Our goal, yes, is to reach the top leadership, senior, C-suite. But more importantly, our goal is to reach 108,000 fellow colleagues to say and be willing to move forward with us in a motivated fashion. So to me, the importance of recognizing who your stakeholders are early on, not discounting anybody. It's a small world, and regardless of how many silos and fractures there are, these worlds collide sometimes, and not for the positive. So understanding who stakeholders are, and the loudest folks that are the most vocal, I would say, pushing back or asking the questions, those are the folks to invite into those conversations. The more you hesitate from hearing that raw feedback and honestly trying to explore it, you're not preparing yourself for success, because they'll come back like whiplash. If you invite them into it, and all of a sudden you're really learning from what they're saying, you may not agree, but it's about acceptance, not agreement. It's about accepting where people are at. And then you may learn that, okay, wait, a slight little iteration may meet their needs and their demands and also accomplish your next goal. So I think it's really important about stakeholders. I think it's really important about being iterative in the process. And then lastly, I'll just say, I think it's really important. And again, this kind of goes back to like the quality world, as well as the implementation science world, as well as I would say medical education world. You need to understand the value of quick wins as opposed to perfection, right? As opposed to getting everything done. Like I mentioned, we're about 12 years into this. We are still in our infancy. And I say that very proud. Very proudly, I say we're in our infancy. We've accomplished a lot, but there's so much more we want to do. And everything along the way has been a vital baby step to get us to where we really need to be. So understanding that not everything's going to be a on-off switch and that you're going to get from 0 to 100, but even getting somewhere and then amplifying that as a stepping stone for the next thing. And in parallel, working on another small win. That's how you really generate mass momentum, in my opinion.
108,000. That's not a small number.
It's not. We're the largest private employer in New York State and the largest health system in New York State. And man, I can't tell you how amazing it feels to be having conversations like this on behalf of Northwell Health and of Hofstra. It's just, to me, I look at our environment as a petri dish for mass change, right? Like looking at it from a researcher point of view, looking at the ripeness of what we could do at scale, could hopefully empower others to say, hey, if they could do that, maybe we can do it as well. And a lot of what we've done has not been like financially supported, in a massive way from our organization. I mean, we've gotten a lot of grants to help us, but it's the sweat equity. It's the ethical commitment and the leadership support that validates our process that has really brought us forward.
That's phenomenal. And, thinking of that just kind of integrated manner and how it's throughout all aspects of everything, that sets the med students up for continuous exposure. It really gets them to the point where that can spiral back through the third year, and it can involve diverse faculty and community voices, and it's just so powerful. How does that cross all the different specialties? I mean, how do you go about it so that med students can continue to see all of these things and the pieces line up?
Yeah, so I feel like, Dr. Bailey, you just brought up the elephant in the room, which is the hidden curriculum. So, and we talk openly about this right from we have a session in orientation for the newly matriculated students around harm reduction strategies and overdose prevention. We bring an individual lived experience. In orientation, I give them a heads up that I wish we lived in an idealistic world, that what they're going to learn in the four walls of that med school, they're going to see out in play in our organization and other health systems as they progress in their career. But the reality is, we know they're not going to see that in play. They're going to see the opposite, right? We're going to teach them A, B, and C. They're going to learn X, Y, and Z, and they're going to see it. And unfortunately, it's going to be forced upon them to accept it because the hierarchy that lives around medical students as well as faculty. But with that said, the solution is within the statement of that problem in itself. The medical students, right from the get-go, we tell them that this is not just an educational offering, but this is to prepare them to serve as agents of change. This is to prepare them as they venture into our organization and others, that they need to model up, that they're walking away with the golden standard after what they learn in those four walls of the school. And now it's up to them, non-confrontationally, but it's up to them to now apply this in their professional development. And along the way, potentially train and educate the folks that are supposed to be training and educating them. So another destigmatization strategy, in my opinion, is that over the years, 100 students per class, We have thousands of students now that are serving as champions for this cause in what they do and how they approach a patient, how they react around the nurse's station when they hear derogatory terms, that overdose in bed 3. No, that's Mr. Smith. That's someone's family member. That's not the overdose. How they offer inpatient units solutions to a patient that may be dealing with an opioid use disorder along with their endocarditis, and offering, why don't we start a medication? And the inpatient team saying, wow, tell us more about it. And then closing the loop of, literally connecting the dots and getting people involved, impacting that patient's life positively, as well as teaching the educators that are destined to educate those students.
And I love that modeling up. That's such an empowering phrase, that you could really leverage that drive that the med students have. They have the interest and the participation, and they really can impact things beyond just undergraduate medical education. They go through GME and then on to CME even. How did your team refine survey instruments, and how did you effectively measure, are they learning what we think they're learning? Are they doing these things? What are some tools that you've identified and utilized?
Yeah, thank you for that question. Yeah, so evaluation is key, right? Otherwise, we're talking the talk, but not really walking the walk in terms of being open to feedback, to iterate, to make sure things are resonating, that there's a positive impact in their learning and their knowledge base, their attitudes, their perceived skills. Evaluation is by far a part of everything that we do, from implementation side of things in the health system, as well as the education side of things in the School of Medicine, the nursing school, community education, and even CME. Can I just comment on something you said? Because I feel it really resonated with me, and I find it really insightful, because I think it's really important that others take a moment and pause and hear what you say. So I may have reflected upon the value that these students bring to this whole equation of destigmatization and changing the culture. But beyond the motivation that they may have, beyond the drive, I think it's up to us to remind our medical students, so that in turn they internalize it. They have tremendous amount of power to influence. It's not just the faculty and the preceptors that influence, I would say, the students. It's vice versa. And when you think about the generational changes and evolutions we've seen in every industry, technology, the airline industry, healthcare, education, it resonates pretty deep when you have a cohort of individuals coming in with a different mindset, a different history, a different background, a different journey, and they're trying to drive, again, what I would frame as common sense. So I just want to make sure that, for all the medical educators and all the other educators that may be listening, it is really important. We're not anyone to actually empower people, in my opinion. The empowerment comes from within, but we need to remind our learners how much power they have to change and influence what the narrative is playing out there.
Absolutely.
Sorry for that sidestep.
No, that's okay. That's okay. It is critically important, because we're seeing that generational shift. The folks that we have coming through now, they are very shrewd investors of their time. They're always looking for that return on investment. And I think that's really what's led to maybe a large part of the success in your program, that they can see the authenticity. They can see the congruence, that it's not just a check the box type of thing. It's not we have to do this thing because it's required. It's something that is true to your core values, to who you are, to who the program is, and it speaks of the philosophy. So thinking of, some of the ways to measure that, it's kind of this intangible thing. How do you get attitudes and behaviors? How do you measure those things, and how do you evaluate that?
Yeah, and sorry about the tangent, but let's circle back to evaluation. But I again, something you said just resonated about authenticity, right? Look, I don't hide it with my tone of my voice, but I'm a New Yorker. we know when someone's walking the walk or someone's just talking the talk. And frankly speaking, I think the younger generation is very keen on picking up on that very quickly. So we have to be authentic. In order for myself and my team to sleep at night, we need to be authentic. And that comes across when not just bringing the hundreds of other voices that we do in the interprofessional manner, but it also even in our evaluation efforts, like we make it very clear to them that they are the future of this curriculum. We demonstrate to them by providing feedback. Even in the orientation session, we talk to them about what iteration we're making based on the last cohort of students that graduated, based on their feedback. We survey these kids all 4 years that they're there, and we also have a post-graduation survey that goes out so we can get upon some of the behaviors, right? Like, were they able to apply this into their practice? Are they still applying it? And then, honestly, I'm a very big fan of pre and post attitudinal and not necessarily knowledge-based questions, but knowledge-based questions are a great baseline for us to at least understand like what we definitely need to insert. But the attitudinal questions about people feeling comfortable, or if they feel people can recover from substance use disorder, or I can make a difference in someone's life with a substance use disorder, or my communication strategies can positively impact someone's journey with substance use. Like, these types of self-reflective evaluation questions have extreme value, because what you're getting is insight before the quote-unquote intervention, the education. You're getting insight of where they're coming from. And then obviously with the delta post, you're understanding if there was impact of the educational offering that you delivered. When we bring folks with lived experience into it, the amount of free text that we receive in our open field questions on the post survey, I can't tell you how many look like journal entries, statements of gratitude, items that resonated with the student and why. So all of a sudden the story share starts coming out in our evaluation framework, where you start hearing about a student that lost their mother, or you heard about a student that lost their brother just last week or last year. So, it serves, the evaluation, in my opinion, is a very helpful tool to drive the self-reflection that's needed. And it gives them, as they would say in the educational world, as well as in the implementation science world, it gives them skin in the game. They firmly believe, in my opinion, that their voice matters. And we're not just asking to check the box. Like, I'm not asking, rate your speaker, like, was your speaker effective? Like, we do that for the assessment side of things, but the evaluation side of things, we really want to get to the heart of where our learners are at, and are we making a positive impact? And if we are, what that impact may be in the short term, as well as downstream in the long term. And I mentioned the spiraling curriculum. So to the best of our ability, our surveys are anonymous. They are matched though. So I can match a orientation record ID with someone that's about to graduate. So I could, in theory, see the progression of that individual's attitudes, knowledge, perceived skills. And I say perceived skills purposefully. Without an OSCE, it is very challenging to actually measure the delta in someone's skill set. So we focus on perceived skills and asking them directly about, do they feel comfortable and confident? Are they able to apply? And, we do this with overdose prevention education, with screening and things like that. But a very thoughtful evaluation protocol that's both qualitative and quantitative.
And that's powerful data.
Yes.
Absolutely. The quantitative, that's the easy stuff. You just throw the numbers out there, but the qualitative, boy, that really has to be powerful, especially when they're beginning to share some of those very deep stories, some of those ways that they've been impacted, not just initially, but throughout the 4 years. How does that work with administrative buy-in?
I love it. Yeah, so there is obviously survey fatigue. We've at a very early stage seeked out IRB approval from our medical school, from our health system. We were very fortunate to have very active decision makers that recognize the value, because we knew right from the get-go this was going to be a lot bigger than where we're starting. And in order for it to get there, we needed to give an opportunity to learn from what we were doing. And I'll tell you, everything we've done in the medical school, we pretty much flipped into GME education. We've pretty much flipped into dedicated CME education that now satiates the DEA requirements for every prescriber. So like the return on investment, oh my God, like, that's immeasurable. I mean, it is priceless at this point. And to then in orientation tell the medical students, by the way, all this great stuff you're going to hear about, it was your fellow colleagues, your upper class people that actually were the visionaries, because they're the ones that provided us the feedback. They told us what didn't work. I remember in some evaluation, we used to get blasted about certain things, and it was our goal to change, and we did, and we kept changing year after year. I'll tell you two other things that are really, I think, interesting. They don't serve as an evaluation. They could, right? Because we could frame it within our survey, but we purposely don't. So, there is another value to doing like post eval, because especially with open-ended, like qualitative, it allows the learner to process, to digest, and get something on paper. So they're not leaving, especially with our sessions, this emotional kind of, what people may say, emotional baggage, and then they get in their car and they don't know what to do with it. So we, a few years back, during our dedicated week in third year that we have focused around our opioid epidemic, we inserted something called the wish jar. So we have a mason jar, and now we universally utilize this whenever we bring anyone with lived experience in. And it's I don't think I have one here, but it's a mason jar. Inside there's these little raffle looking tickets that say wish on them. We hand out these wish tickets individual to every single student. And we say to them that as you're listening to the individuals that have dedicated their own time to come speak about their lived experience, share their vulnerabilities, open up to questions, we want you to document on the wish ticket a statement of gratitude, something that resonated with you, something that you're walking away, like a takeaway, just whatever you want, some message to share with that speaker once they leave these four walls. And that wish jar, and I wish I had, no pun intended, I wish I had, I actually have a slide with feedback from our speakers, but it serves as such a palpable exercise, first and foremost for our students, because it allows them to really connect the dots and put something in writing to that speaker. And a room full of 120 people, it's challenging sometimes to raise your hand, share a statement of gratitude. You may be going through, revisiting your own traumas about this topic. They're documenting a brief reflection, a statement of gratitude that no one else is going to read. My team does not read these. We put them in the mason jar, close up the jar, and as a thank you to the speaker, we hand them the mason jar with some disclaimers. We say to them that, one, this is your way to realize and feel the impact you had with these students. Because a lot of us, when we speak, we go home question, right? We second guess everything we said. Did I say that right? Did that work? Should I have said that? So instead of putting these folks that are showing so much vulnerability in that position of questioning everything, let's just give them the answer to their question, which is, did I resonate? And yes, you obviously did, because there's 120 wish tickets in here. But the second disclaimer is, do not open or read this until you get home and you're not driving. We had one of our speakers who opened this up in the parking lot at the med school. And 3 hours later, I was still there. She calls me crying, bawling, because it was just so emotional about what these students were sharing about their own journeys, about what that person said, about how much they remind them of their mom, like all these different things that come out. So it's not part of our evaluation framework, but to me, it's an important exercise to allow for some debriefing of both the students, the learners, as well as our thoughtful community members that come in and share.
That's such an amazingly psychologically safe way to provide closure. You know, some of those things, it's rip off the Band-Aid and they have an awareness and they walk away from that. And that's a tough way to kind of feel like, what can I do? So it automatically provides that opportunity to do something, to give back. And that facilitates that mindset, that other-centeredness. And that oh my goodness, that is tremendously powerful.
I mean, Dr. Bailey, we're literally demonstrating to them how much power they have on this small little wish ticket, right? And to your point, they're already putting their thought process into action. We're not waiting. We're not waiting for downstream. We're asking them to act. And then lastly, about the safety aspect, we're very clear. My team members, anybody, we do not read these. We do not read these. So it is completely up to the students to do whatever they want at that moment. And we trust them that they're not going to write something negative. We put the words matter slide up, so we want them to be very thoughtful in the language they use. But this is all them and our speaker directly.
That's phenomenal. So I know we just have a couple of minutes left. I just want to ask you, any ultimate words of wisdom or encouragement for those that are listening and watching?
Oh, God, I don't know if I'm anyone to give folks words of wisdom. I would just say there is a misnomer, especially when you hear me say something like we're a large organization, we have 108,000 here. There's a misnomer that like, oh, there's a lot of funding behind what you're doing, where everyone's supportive. I promise you, from large organization to the smallest organization, it's the same issues and the same problems that need to be navigated. It shouldn't be a debilitating factor. It actually should be an empowering factor to find opportunities in whatever challenges are posed in front of you. If it's at a medical school and you're being told that there's no session time available, well, then try to partner with some like-minded students and do an evening event for one of their interest groups or one of their clubs, and allow them now to become the champion and say, wow, we had so many people that came. This is what they said about it. We really think we need a session about it. And we have definitely benefited from student voice in our evolution in bringing this. And then, lastly, we got to remember we can learn a lot from our learners, especially this generation. They have seen a lot when it comes to substance use and substance use disorders and overdose. So they are stakeholders. They're not just learners, and you need to bring them in. And we've been very, I would say, privileged to bring in a lot of our medical students into our journey, who then become educators. Right in orientation, we have first-year medical students educating the newly matriculated students, the rising second years educating the first-year students. So understand the value that the learner pool brings to this equation as well.
That's amazing. I want to thank you so much for your insights. It's been incredibly valuable. It's very clear that your work is a model for humanizing this type of work in medical education. It's really fostering a culture of understanding and competence. Dr. Wyatt.
Thanks, Dr.
Boy, that was outstanding. So thank you both for a most valuable discussion. Dr. Bailey, for your insightful questions, and Dr. Kapoor, for your eloquent description of your work. You really do a beautiful job of talking about this. So thanks again. As we sign off, I encourage you, the viewers, to look forward to upcoming videos in this series. We will be recording sessions on improving awareness of substance use problems as students rotate through their psychiatry, and then a third video will be on rotating through pediatrics. These should be available within the next few weeks. For more information about COPE's work, I encourage you to visit the copenow.org website and write to us to gain more information or join us in our efforts. So thanks again to Dr. Bailey and Dr. Kapoor, and thank you all for watching this video.